today we have the great pleasure to have Hakim Benamer with us. Hakim, can you please introduce yourself?
Hello. So I'm an interventional cardiologist. I work at Massy. I work also in Hôpital Foch and La Roseraie, which is a center in the north of Paris.
So Hakim, I guess as an interventional cardiologist, you have been a user of the radial access for many years. What was the trigger for the cardiology community to switch from femoral to radial?
The trigger was really simple. It was the fact that we had a lot of hematomas by transfemoral access, especially for overweight patients. And so the fact was to reduce this rate of complication. We had to use this new access, which was the transradial access.
Could you give us some general lessons you've learned using the radial access for more than 10 years?
The first issue was the puncture. We had to exchange with the colleagues a lot of tips and tricks to have the highest success rates for the puncture. So that time was very important. It is the first step. So we had to perform an anesthesia on the area of the puncture, and the first message was to reduce the pain for the patient, because when we had the pain, then the rate of radial spasm increases very importantly. So this first knowledge was very important for us. Then we had to deal with the pain, and the pain reduces and the spasm disappear. Not completely, but reduces a lot.
Okay, so would you have like some general advices for, let's say, a trained INR physician that is about to start his radial experience?
Yes, first you have to start your radial experience with the simple radials. So first begin with good pulse, young patient, and especially a male patient. That's easier.
So moving to patient preparation, do you use any kind of premedication drug?
Yes, we use a small sedation to reduce the spasm of the transradial access and to reduce the stress for the patient. And sometimes in the private institution, we have anesthesiologists, so we are using remifentanil to have a patient very relaxed.
Do you use any local anesthesia cream, and would you have any recommendation for its use?
Yeah, we use EMLA cream, which is very efficient to reduce the feeling of the puncture and the pain of the puncture. But you must put the cream 2 hours before the puncture to be sure that it will be okay.
Do you use collaterality testing before puncture?
At the beginning, we used the LINNC test, but now we never use the LINNC test because the rate of radial occlusion is very, very low today. And we don't have any problem, even when we have an occlusion of the transradial access.
Do you use a proximal or distal radial puncture? And could you comment on which location is better for which situation?
I use usually the classical transradial access. For the distal radial access, I use it when we have a huge spasm of the transradial access, which sometimes is easier to perform the puncture and then inject nitro inside and have a good pulse again on the transradial access.
Do you use a venous cannula or do you use a bare needle? What do you recommend?
We use the venous cannula in 80% of cases, but sometimes when you use the venous cannula, when you have a very good pulse coming from the venous cannula, you try to introduce the wire inside, and it doesn't go inside the artery. So at that time, I use a bare metal needle to make the puncture, and to be sure that I can orientate the whole of the needle, and then introduce a small metallic wire with the bending. And with this puncture, it is easier to find the good way to introduce the wire inside.
Speaking of sheath, what's the maximum size that we can use?
We are able to put 7 French catheter in 70% of male and 50% of female. So the rate of using 8 French by transradial access, I don't know it, but it is, of course, less than 50% for female. So in our practice, we never go more than 7 French by transradial access.
And what about the ulnar artery? Is it okay to use the ulnar in case you have a small radial, or is it dangerous?
No, it is not dangerous, and it is a good solution when you have a small radial artery, because usually the ulnar is bigger. So it is a good solution when you have a very small radial access. So you have to use it.
What's your cocktail recipe?
We use verapamil, 2.5 milligrams inside the artery, and the heparin also is injected in the transradial access. Usually we use for an angiogram 5 international units of heparin.
And what about nitro? Do you use only verapamil?
No. Usually we don't use nitro inside the radial artery, because it is very painful, and the pressure goes down deeply with the nitro.
You said it. Sometimes the patient will experience pain and a burning feeling into the arm. Do you have any advices to reduce pain?
First of all, you have to explain to the patient that he will feel a burn when you inject the cocktail. That's a very important step. You have to discuss with the patient to be sure that he will not have more stress, a lot of stress, because with the stress, he will have spasm, then pain. With the pain, increases the spasm, and so on.
Let's speak about hemostasis. Do you use any system for compression, and what would be your tip and tricks for performing an adequate hemostasis?
It is a very important step of the transradial access. The compression of the radial is must be done with the dedicated system like tear bond and so on. And we have to make a compression of the transradial access with a patent cubital. That is very important. And the other point is the fact that you have to do this compression not more than 2 hours, because if you let the system too long, then you will have a real increase of the radial occlusion.
So what would be your standard time of
usually we use
7 French?
For a 7 French, usually we use a tear bond in our practice, and with the tear bond, with 2 hours of compression, it is enough to have no bleeding and a very low rate of radial occlusion.
Do you think the neuroradiology field should continue and pursue this radial journey? And second part of the question, what do you think is needed for the neuroradiology field to do a global transition towards the radial access?
I'm sure that it is very important for you to use the transradial access. You will reduce the rate of vascular complications. The second point is you must have the experience and you will have it if you use the flooding technique. At the beginning, you use simple accesses to perform the first experience step, and then flooding technique, all patients done by transradial access, and you will have the experience to do every cases.
Thank you, Hakim. It was a pleasure to learn from you.
Thank you very much. It was very interesting also.
Thank you.